All right, while we're getting organized here, I got to ask the obvious question for Dr. Dasgupta, because I get it all the time, which is, so putting unexpected drugs into your customer's product that ends up harming them doesn't seem like a sustainable business model. So why does this happen? Do you have any more insight than you had the last time I asked you this question?
Was that
Every year?
Yeah, I think we have had more qualitative studies where we've been able to find out more a little bit further up the chain. So I mean, it's fascinating because the adding stuff, it's very common to add stuff. I mean, it's like, this is a very bougie analogy, but I think this is the right audience. The difference between American wines and French wines, right? Where French wines are mixes and blends of different types of grapes, whereas American wines will say Pinot Noir or Merlot right on the label, right? So there is a natural tendency to blend substances, psychoactive substances. What we see is that there's a very strong regionalization. There's regional flavors of the drug supply. So in Michigan, for example, a lot of Benadryl, like when we see fentanyl, it usually has Benadryl in it. When we see in New York, it usually has Procaine, which is like Novocaine in it. Yeah. So there's like these different local flavors. So I think part of it's adapting to local demand, and people are tired of fentanyl, right? Like fentanyl's been around long enough. It's not ideal for a lot of people. So I think there's a lot of demand for more innovation in the drug supply market. And part of what we see with the addition of all these different substances is that being kind of, trying to meet customer demand. So that's part of it. There's a lot more.
Great. Good answer. I like the innovation aspect of that because people are always innovating and sometimes they don't get it right, and what they're putting in there is not a good thing. Great. So Marta, one simple thing that occurred to me while you were speaking is, so when the sponsor has to include the availability or the potential for returning a drug that FDA has implemented, where does that drug go? What happens to that? I hope you're not just having a party back at FDA.
Well, it's not coming to FDA. So no party. So essentially, in the current framework, we are considering implementing mailback envelopes.
Right.
So these mailback envelopes are regulated by USPS, so US Postal Service, as well as DEA, and these mailback envelopes will go back to the incineration centers where they would be incinerated.
Yeah, okay. So that's not well, I won't go down that path. But you talked about this new DMI tool, and Joshua and I and the whole team are very interested in that, the literals, and how we can actually have a better concept of everything that was involved. Do you think this is going to be available nationally, or can you give us any more information about that on national data sets? You've told me that you can use it on local data sets, so maybe you could expound upon that a little bit.
Yeah, so the tool itself is publicly available at that link. The kind of question I think you're asking is, like, what about the input data? Like, where can we get the literals?
And
I think a lot of states are willing to provide that to researchers, but on a national level, it would all have to kind of go through NCHS at CDC. I think their biggest concern is that inadvertent disclosure of publicly identifiable information, like case record numbers and others things, being put in the literal text field. So I think, Joshua, you've done this in real life and gone to the data centers. So I don't know when there's a parallel effort that's being led by by NCHS to use a very similar classification system to redo the way the national numbers are calculated. So they'll be baking some of that in, but in terms of actual literal mining, I don't know that they're planning to do that anytime soon, but maybe you know better.
Hey, Joshua, you want to answer that? Yeah, that's
Yeah, I'm in the same place. I don't know of a current mechanism to be able to get the national level, national coverage of all the literals. I think the best current source would be to go individually to states, as you say, and collect them from that method.
But I think you contacted CDC and CHS to ask if they were going to make the data available in a form that could be analyzed, and the answer is not currently?
Not currently, yeah.
Yeah, just so, because there may be researchers on wondering about this, and it's a very interesting data source for sure, but right now there is not a plan for, we used to write some papers looking at this for the whole country, and we can't do that currently because we don't know when those data with those literals identified that we can actually put into the system that NAB and his collaborators have designed. So, good, thank you. Is there anything, I'm going to ask a strange question for the panel, which is, when you were listening to someone else's talk, what struck you as strange to you or something that needs to be followed up on? Song and dance time, folks.
The counterfeit data were really fascinating. I don't think I've ever seen anything like that before. I would want to follow up, cross-tab every single one of those in every single way possible.
Yeah, I mean, I think for me, I just to understand kind of how all of those work in concert, I think is the next step, because you can look at them as one of the questions was, you can look at them individually, but it's when you look at the whole person and all the behaviors that they're engaging in, and then just kind of parse out those, I think is the next step where I'd like to take all that.
Yeah.
If I can add to it, it's interesting that we actually all had overlapping topics across the different presentations, and with the falsified medication, it's so interesting to think about what we've learned from the online pharmacy summit and how people are getting the medication, how many people are not aware. And it's also depending on the age ranges, which also you mentioned, how many people actually anticipate that they potentially could be exposed to falsified medication versus people who do not know. Also understanding how recent these really new patterns. Some of them, some people have been taking or purchasing medication online for quite a long time, but there is really an influx of people who are doing it right now. Is there an opportunity, and how do these people compare to those who've done it a while back? Also, understanding what do people really think when they are buying medication online? How many of them really believe that these are regulated pharmacies, which is versus those who know that they are not regulated. The fact that you don't need prescription. Some people might cue some people, but might not others. So really having an understanding how to merge these two information, it would be great to hear your presentation as part of the next online summit. And also information that you've mentioned regarding the temporal correlation between the last prescription versus the overdose death. I think that's really interesting. It goes to the issue of the questions that we've all been discussing a number of times at various forums regarding demand. What is really driving the demand? Because frequently we focus on the supply. And it's important that we focus on the supply, but truly if we don't address the issue of demand, and what is really driving the demand is really critical. So if there's this temporal 3.5 years, it's a fairly long time period. Is it a predisposition that is being created? What are the factors that are really driving it? I think it's something that we really need to explore further.
There was a interesting commentary by a former commissioner of FDA, Gottlieb, and he wrote in the New York Times, I think it was recently, a pretty extensive attack really on our current approach to opioids. And it gets back to the concept of every system is perfectly designed to produce what it produces. And basically his allegation in this is very much that there's lots of other things we could do to affect the supply side. Now I have to say, I went and decided to look this up a little bit, and clearly the postal system has added lots of inspectors of the postal services so that they can try to detect illegal shipments, but clearly large amounts of illicit drugs are getting into the United States on a regular basis. In fact, Dr. Gottlieb even mentions in some cases that it's actually shipped into the United States first and then moved over the border to Mexico. And so it's a fascinating issue of there's a pretty obvious problem there, and what can we do to address that? These are not we aren't the right experts to address that question, but if anybody has any thoughts about that, because I've always said demand, just what you said, right? Last year I made a big deal, demand, demand, demand. Until you get rid of demand, you cannot do anything much. But the reality is the demand seems to always be there, and I don't see us making much progress on the demand side of the equation. So that only leaves supply as a potential way of intervening here. I don't know, any thoughts about that? I mean, it's, unfortunately, it's not really prescription opioids, at least not right now, that are the issue, but.
Well, the only thing that I can mention is that, we recognize that, there is an area of, that we both, FDA as well as our federal partners and others, we're looking forward into making sure that we have as robust system as we can. But the truth is we don't know how much of this drug is coming across the border. We know what we can catch and what we have detected. What is undetected, that's somebody knows, but they don't want to share that information with me. So there is definitely an issue, and that's why trying to figure out why in other areas of the world they don't have this issue. I think that trying to determine what are some of the demand factors that are present in here and are not present as much elsewhere. Maybe that is something that's going to give us a better cue. Though even in Europe right now, there are a number of questions that have been brought up and some concerns that we have heard about potential influx of fentanyl, for instance, to Europe, especially now the heroin supply is somewhat decreasing.
Yeah. Ned, looked like you had a thought.
Yeah, I think demand is also a very big word and very heterogeneous. I think there is kind of demand for, what we hear too is like, because fentanyl has been around a long time and because people don't like it as much as they used to, that people are looking for alternatives. And so the demand isn't like just molecule based, it's
right.
kind of class based. And then I think there is a demand. I mean, we saw it with the buprenorphine diversion data, right, of people wanting alternatives to make them not feel sick, but also not get them so high that they're not, that they can't function or are falling asleep, right? So there's a fairly large customer base that has this kind of alternate demand profile. And so while I don't know if we can measure that overall demand is going up or down, we can definitely see that the type of demand is changing. And is that, so I think that, I would push back and say demand has changed, but it's not just a matter of like up or down, but more qualitatively we can see that.
I'm not saying it's not changing. I'm just saying that we can't seem to reduce it. And to be honest, I can think of ways to do that, but they would take societal change, because it seems to me the message here with all these drugs that are increasing. I mean, throughout the history of substance abuse, obviously, they've come and gone, T's and blues, and I mean, you can name it, every generation, there's one or two different ones for sure. But clearly, there is a crescendo that we have developed in the last 20 years, and it extends to all kinds of things, even diphenhydramine, as we were mentioning. And so what's driving that as a society is a huge issue, but also it'd be a huge lift to try to fix it. And I think I go back and forth about Dr. Gottlieb's position here is, my first response was, well, that's impossible. You can't possibly interdict that much. But then I get back to what Deming said, and it's like, well, that's the problem. So if you're going to address the problem, how do you address that part of the problem? I mean, you could have 10 times as many postal inspectors as we have now, or 100 times as many. You probably could intercept a lot of those. But anyways, go ahead.
But are you going to just incentivize innovation? And if that supply is going to be limited, would there be another source of supply that will be developed, right? Because if there is demand, there will be supply, very likely. So are we going to see more domestic production of methamphetamine if methamphetamine from Mexico is not available? Are we going to see Smurfs again and domestic labs, clandestine labs that we've seen sometime before that we were able to eliminate in large extent? So that's always the question. And also when we are looking at demand, I think that there are two different components. First, demand is for initial exposure. Why do people start being exposed to the drugs in the first place? Right? And then there is the demand for people who are already in a substance use, who have substance use disorder or have like extensive experience. So they might be chasing for a different version of the experience or to address the withdrawal, whatever would be the factor. But I think that we have to make sure that we differentiate these two types of demand because they are not, may not be the same.
Well, then I would add in between demand and supply is how demand kind of gets satisfied. Like, does someone have access to the care that they need to fulfill the demand in a way that's safe and effective? Do they have, or do they have the knowledge they need to know that an online pharmacy is not legitimate? The way demand gets taking, like a person meets it, also fits into the equation of what they end up getting, what risk they end up getting exposed to.
Okay. This is this one's a long, or potentially long and complicated topic, but everything we do, we talk all the time. In fact, in this last conversation, we were tiptoeing around the issue of intent, meaning what was the person trying to do? And it gets back to my pain question, which is, not all pain is pain, and not all misuse is misuse, or not all misuse is abuse for sure. And how do we parse those? I've become, less enamored of non-medical use as an indicator for serious events. They do correlate to some degree. So Josh, I don't know if you want to comment on this, but it's like, how can we get a better feeling for what the person actually intended rather than just what is in their blood, for example, or when they're right, the coroner, I'll give you some more time to think about this. So the coroner, I'm the coroner, and I do my umpteen labs, right, and I get this thing back that has 10 different things on it. A good medical examiner or coroner will try to figure out whether or not which one actually contributed to the death, and sometimes you can tell from the scene investigation that can help you. But a lot of times you don't have anything, and all you have are concentrations that are postmortem concentrations, which are very fraught to interpret, very difficult to interpret, because they can be surprisingly high or low depending on how long the body has been, how long elapsed between the time of death and the time of testing. So did I give you enough time to think through this? It's
Yeah, so the question was, how do we better think about non-medical use as like
right.
a larger topic? I think we're still using terms that have been around for decades, and so to me, I think it's always important to step back to the individual who may be using for different reasons and reevaluate: are these still the right reasons that
Yes.
they've chosen to use? Are these still the right avenues that they've chosen to use? I mean, we were just talking earlier with Carrie about different ways we need to change the way we ask about these behaviors, because it's not the same way as it was even 5 years ago when we launched the survey.
right. Any ideas how we would do that, though?
Like mechanistically?
Yeah, like actual.
Well, yeah, I mean,
If I said tomorrow, Josh, here's unlimited funding, I want you to go do this, then what would you do?
I'd start with a cohort of individuals who report use and ask them kind of open-ended questions and really just tell the story. Like, what are you experiencing? Why did you get here? How did you get here? Did you want to get here? Would there have been a different path that you wanted to follow but weren't able to? I'd start with the person.
Yeah. I mean, it strikes me that we're doing much more of that in the psychedelic work. That will come this out after lunch, but
Dr. Dart, we have a question from the audience,
Sure.
both on the virtual audience, but we'll take the one here in the room first.
sure. Where are they? Is this like a treasure hunt? We have to figure out who they.
All right, we're going to actually move to the virtual audience. So this is a question for Dr. Sokolowska regarding the mail-in envelopes. Has the FDA developed a process to mitigate illegal interception of the envelopes on the mail? And is there a tracking system to ensure that the envelope arrives at the destruction center?
Interesting.
So mailback envelopes are regulated by U.S. Postal Service as well as DEA. So there is, we have developed these, when we are considering developing these programs, we've been in consultation with those authorities, and it's part of a whole broader system of overall how mail is being tracked. Currently, we do have a lot of mails, opioids and other prescription medication in mail. So this is not going to be very different than the situation that we have already. But again, we rely on our partners who already regulate this space in order to make sure that it's safe.
Okay. Jess, anything else from the audience? Oh, here we go. We have a question here now, Jess.
Hi. Adi Ray from Legacy Research Institute in Portland, Oregon. One thing I was really surprised that I didn't hear today discussed was the emerging cannabinoids, hemp-derived impairing cannabinoids. So there's definitely poison control data about pediatric poisonings, there's cardiac events, psychotic events, ED presentations, and there's this weird overlap Venn diagram happening where these are somewhat counterfeit for cannabis and not regulated by the FDA, not regulated by USDA, and yet a major emerging, category. So I'm really curious, sort of from all of you, how you're thinking about the interface of, potential changes to Schedule III for cannabis itself, how the Farm Bill is going to potentially, change how hemp-derived cannabinoids are regulated. How do we do surveillance on these products? Just in general, this has got to be on your roadmap, right? So what are you thinking?
Well, as a general statement, we do monitor various cannabis derivatives, and there just wasn't room in the agenda. So I'm certainly happy to have the topic discussed, though. And Nav, looks like you're chomping at the bit, so why don't you go first?
I'll be brief, but yeah, synthetic cannabinoids is something we test for, and we've worked with cannabis management authorities in different states because it's not just a matter, there's a lot of variability in synthetic cannabinoids, like molecule to molecule, right? And so what's in one packaging is not always the same week after week. So there is kind of like that level of variation. And then we also have seen specific cases where the synthetic cannabinoids, which looked like general weed packets, also contained nitazines and benzodiazepines and other things. So there is it's like illicit, it's like not regulated manufacturer, and then there's adulteration of not regulated manufacturer within this context of legal regulation. And so our efforts have been to kind of help certain state cannabis authorities kind of work with local harm reduction programs to set up a monitoring system for what is actually in synthetic cannabinoid labeled or sold as kind of supplies. And we were able to tamp out one overdose outbreak that was related to a contaminated synthetic cannabinoid supply. So I think there is lots of room for kind of on the ground integrating surveillance with people who can actually interact with suppliers and say, cut that out, that's not helpful, don't put that in there. So that's where I'd go.
Can you amplify that example you just mentioned? Because I think where the rubber hits the road is what I and many people have trouble with drug checking and things like that, is how the feedback mechanism can actually be fast enough and to whom in order to have an effect. So
yeah, I mean, we see that time and time again where there will be something with something really unexpected and nasty, might have caused a bunch of overdoses, fatal or non-fatal, and then we provide those results back to the harm reduction program, and the individuals who provided the samples, and they go to their suppliers. One of the requests that we had on our website is to have a print button, and they print out the results and say, this is what was in that. These are the people who got hurt from it.
Yeah.
And then sometimes we hear back that, yes, batches were destroyed and people got rid of whatever was happening. And we've seen the data like very locally, not in North Carolina, but of outbreaks that got tamped down because this information went back and made its way into the supplier chain, and they destroyed those batches, or more likely shipped them elsewhere.
Yeah. And, I mean, what is FDA's position on cannabis these days? It's
Next question.
okay. All right. Josh, anything to add?
You want me to add to FDA's position on cannabis?
Yes. To the general question, it's
Yeah, I mean, I think as we've already seen from NISTA data, cannabis is by far the most used substance, and the dearth of data on the specific variations, derivatives, behaviors, types, combinations that are being used there's just a huge lack of that information. So I think,
yeah. So interesting, and to go along with your comment. I guess it's about 9 months ago now, the Denver Post ran a story about cannabis and basically said it's been 10 years of legalization and see, nothing happened. And, I read that and I was just stunned because we do collect data on this. Clearly, there's lots happening, but somehow it's another one of those topics that politicians, whoever, has gotten desensitized to because nothing seems to be happening. Andrew has done some work on this, Dr. Monti, and has published it. It doesn't get a lot of traction with the people who can actually make a difference. And so it's a great question. And if we have any suggestions on how to make that work better, because it seems for me, just at a high cut of the data, you could easily identify higher risk populations where you could do risk reduction type of activities, harm reduction activities. But as far as I can see, not much of that is happening.
Question here in the room before we break.
Okay.
If I could just add something
Sure.
to it. One thing that have not been really discussed much is treatment for cannabis use disorder. So that's one plugin that I really want to do, because the NASDAQ data that I presented before and a number of other data sources have demonstrated that we do have people that have developed substance use disorder, cannabis use disorder.
Oh, yeah.
And currently we do not have FDA-approved treatment for cannabis use disorder. Frankly, we don't even have a guidance for cannabis use disorder treatment development. And there's not much of public discussion regarding what would be it, what are the frameworks, what are the barriers, what are some potential molecules or even devices to be used for that. So I think if anything, from my perspective, I would put a plug-in that it might be a topic for future discussion to make sure that as we are discussing substance use disorder more broadly, we don't forget about cannabis use disorder or alcohol use disorder or many other disorders that have not been really recently researched as much, or at least we haven't had approvals for new products, because we know that there is a need.
Okay, great. Question? Go ahead.
Yeah, hi, I'm Karuna Nerurkar from Shamsa, and I believe that in online controlled substances summit, it was mentioned that, when the data comes, when the drugs are being shipped to United States, a lot of time they are being shipped, I think, from China, and if certain substances are controlled, they go to on the next level, like other compound which is similar, but it's not controlled, and those kind of substances are being shipped in the country. So my question to you is, when you test, when you do drug testing, do you only look for certain substances, or if there is a new substance that is coming, you have technology to capture that, and where do you report it?
Like a precursor, you mean? A precursor substance to the...
Right, like a new substance, which is chemically similar compound, but it has the similar effect. So that would be a new substance that is not yet, in a registry anywhere, yeah?
Yes, we do untargeted search, so every molecule that we detect, we trace down, we do library match, order the pure standard, and confirm it. So yes, we see every new thing, everything we see, we positively identify to the level of being, to like a very high scientific agreement. Yeah.
Some test only can find 6 substances. You can find all the substances and their
Yeah.
concentration also?
We do all the substances. We could do concentration, but we choose not to at this point, just because we want to be high volume and quick. But yeah, we get anything that's detectable on GC, we will track it down and we will make a positive identification.
And do you have a somewhere, like how do you report it? Like if you're finding substances, whatever, is there a mechanism to report that?
Yeah, it's a public, all our data get published daily, our data are published daily. So there's all on the website, it's there. We have a list of substances we've detected with frequencies, it's all there. But we are intentionally a service that is intended to help people with better choices about what they put in their own bodies. We are not interested in being part of the policy and bigger kind of national conversation. We want to help individuals and we want to help the people who are helping them directly.